Hi, guys. Thanks for keeping on listening. We are away on parental leave right now.
Yes, but we still wanted to make sure that you guys had content to listen to while we were away. So here is one of our oldies but goodies.
Check out the website for some updated notes on this particular episode since our recording. Hope you enjoy, and we'll see you when we're back. All right, guys, welcome back. This is Nick.
This is Faye.
And this is
Creogs over coffee. Today we have with us Dr. Lindsay Beffa. Dr. Beffa is an associate professor and clinical educator at the Warren Alpert Medical School of Brown University and Women and Infants Hospital, and one of our lovely gynecology oncologists. Welcome, Dr. Beffa.
Thank you for having me.
All right, Dr. Beffa. So what are we going to talk about today?
So today we're going to talk about endometrial cancer. We'll go over a few things. I wanted to talk about the different classifications and types of endometrial cancer, and then we'll go through some risk factors, how to diagnose it, what the symptoms are, and then, of course, treatment and staging.
That sounds excellent. So first of all, Dr. Beffa, what exactly is endometrial cancer, and why do we care about it?
So, especially in this country, endometrial cancer is something that we should all care very much about. So we use the term endometrial cancer, we throw that around really easily, but to break it down, endometrial cancer is just cancer of the lining or the epithelium of the uterus. And this accounts for more than 90% of uterine cancers. So if somebody says they have uterine cancer, you can almost assume that what they mean is endometrial cancer. The rest of the types of uterine cancer are from the mesenchymal, stromal, muscular layers, and those are kind of a whole different ballgame that we're not going to talk about today. We're going to focus on endometrial cancer. But specifically in this country, it's the fourth most common cancer that affects women. And we'll get to the risk factors and it'll make a little bit more sense, but it is definitely increasing in incidence. So everyone will come across this.
And I've heard too, Dr. Beffa, that there's different types of endometrial cancer.
There are. So what you'll read most at this current point in time in textbooks and likely on an exam per se are types 1 and type 2 endometrial cancers. So what that means, type 1 is kind of your bread and butter, most common endometrial cancer. Those are the ones that are estrogen driven. They're typically low grade. So for us, that means either grade 1 or grade 2. They have endometrioid histology. They're favorable prognosis. They're easy to treat, usually to present at an early stage. And this is the majority. 80% of endometrial cancers are this type 1. And then type 2 are high grade. So that either means a grade 3 endometrioid histology, also serous, clear cell carcinosarcoma histologies. These are typically more aggressive. They have a much poorer prognosis and luckily account for less percentage, about 10 to 20% of endometrial cancers.
Dr. Beffa, can you just break those grades down for us again? What does it mean to be grade 1, 2, and 3?
Absolutely. So this specifically is a little bit different in endometrial cancer. So we think about grade, the way we say this to patients, we think about grade as what do the cells look like under the microscope? How atypical, do their nuclei look? How many mitotic figures do they have? But when we talk about endometrial cancer, it's actually how much solid component is there, because the endometrium is a glandular epithelium. So you would expect for it to have glands. But the grades in this type of cancer essentially mean how much solid component does it have. So grade 1 is less than 5% solid component. Grade 2 is 6 to 50% solid growth pattern. And grade 3 is over 50% of the solid growth pattern. So I feel like that is kind of a classic because it's unique to endometrial cancer. And that's a classic potential question that may come up.
Got it. Thanks for that. And I guess kind of jumping back into now those types of endometrial cancer you're describing earlier with, are there risk factors, I guess, or things that we should be picking up in a history or physical examination that would pique our attention for a type 1 cancer, let's say?
Absolutely. So again, these are the type 1, these are the estrogen-driven cancers. So you have to think about both sources of exogenous estrogen as well as endogenous estrogen. So we're seeing less of this, but you still need to keep it on your radar if you're seeing patients in clinic. But so exogenous estrogen, if somebody has been receiving unopposed estrogen and hormone replacement therapy, if somebody is on tamoxifen, those are things that you should be thinking about. And then of course, endogenous estrogen, kind of the classic, and this is a big reason why this is increasing incidence in the US, is that because of obesity, and then any other kind of causes of chronic anovulation. So whether that's polycystic ovarian syndrome or the menopausal transition, and then of course less common, but again, classic potential test question, are the estrogen secreting tumors. So classically the granulosa cell tumor of the ovary. If a patient has abnormal uterine bleeding, you think about an endometrial cancer associated with that. Other things that are risk factors that are actually totally separate from exposure to estrogen is diabetes also increases the risk of a type 1 uterine cancer or endometrial cancer and nulliparity. Other things that are hot topics right now are genetic causes of type 1 endometrial cancers. So classically, this is Lynch syndrome. So again, those genetic mutations are in the DNA mismatch repair proteins, and that's MLH1, MSH2, MSH6, and PMS2. So it's autosomal dominant disorder. And then the one that's less common, but not to forget about, is Cowden syndrome. And that's a PTEN mutation. And again, that's an autosomal dominant pattern as well.
So now that we've talked about these risk factors like these different genetic things that predispose you to having endometrial cancer, as well as risk factors like exposure to estrogen, are there protective factors?
Definitely. So progestin-containing hormonal contraception, kind of in any form, is protective, as you can imagine. This makes sense. And then other things that are not nearly as strongly protective, but to think about and keep in mind, are things like breastfeeding, increasing gravidity and parity, and then always, and if some of you may remember from medical school, the whole idea of smoking is protective in endometrial cancer. So there is still, don't necessarily tell patients that, but there is still some protection in related to smoking with type 1 endometrial cancers, but only in the postmenopausal patients. And obviously, all the risks of smoking don't outweigh this benefit, but that is true.
Interesting. Right. Moving on from type 1, though, because again, type 1 accounts for 80% of these endometrial cancers. What about type 2, the sort of less common endometrial cancers, though, that are higher grade?
So those, are not estrogen sensitive, not estrogen driven. So those are a little bit trickier. Kind of some differences from type 1. These patients typically are older in age at diagnosis compared to type 1. The type 2 patients are typically thinner. Now, with all this being said, obesity is still a risk factor for type 2 endometrial cancers.
Thanks so much for that, Dr. Beffa. Let's switch gears for a second and kind of talk about the clinical picture. So how would someone with endometrial cancer present in the clinic?
So 75 to 90% of patients come in with some form of abnormal uterine bleeding. And the amount of bleeding does not correlate with the risk of endometrial cancer. So this always needs to be on your radar. So whether that's premenopausal abnormal uterine bleeding, obviously any postmenopausal bleeding, this needs to be really high on your differential. But, even patients who have been worked up for abnormal uterine bleeding premenopausally and have not had a biopsy yet, if that persists, I highly encourage you and stress the importance of an endometrial biopsy or some type of tissue sampling. And then other ways that it might present or it might be picked up are people may have an abnormal pap. So you may see atypical glandular cells on a pap, and that may be the first thing that kind of triggers you into the pathway of finding this, or incidental finding on imaging. So whether that's CAT scan or MRI, but classically it's an ultrasound with a thickened endometrial stripe.
And then, so say we do get some suspicion, whether based on risk factors and some presentation generally of abnormal uterine bleeding. Is the endometrial biopsy the way to go, or are there other things that we should think about in terms of cinching a diagnosis?
Yeah, so, the reality is most of the time endometrial biopsy works very well, and it's a good kind of first start. but it's most reliable if at least half or 50% of the endometrium is involved. So if your endometrial biopsy is negative and they have persistent abnormal bleeding, don't just assume that it's correct. And kind of the next step or the gold standard would be a DNC or dilation and curettage. And that's with or without, but I would say most of the time you're doing it with a hysteroscopy to evaluate and visualize the endometrium.
So I think up to this point, the general gynecologist could probably work up somebody who has endometrial cancer. But once that pathology comes back with endometrial cancer, we're probably sending them to you. So what would be the next step for treatment?
Yeah, so treatment of endometrial cancer, as long as we in the clinic on an exam, don't notice kind of things that make us concerned for obvious metastatic disease, but the treatment is surgery. So endometrial cancer is surgically staged, which is different from some of our other cancers. But so what that means is most patients need a total hysterectomy, a bilateral salpingo-oophorectomy, and some sort of lymph node evaluation. And this has kind of changed over the last few decades. And so now we frequently do sentinel lymph node biopsy, where you're just taking a couple lymph nodes versus a full pelvic and periortic lymphadenectomy. And as far as how and what route the total hysterectomy is, there's been actually multiple trials for endometrial cancer that have shown that minimally invasive approaches have, as you can imagine, lower rates of perioperative and postoperative complications versus an open procedure, and it doesn't negatively impact oncologic outcomes. So minimally invasive surgery for endometrial cancer specifically is very appropriate.
So we do surgery, and now we're moving on to actually staging, sort of the bane of everybody's existence when it comes to tumor boards across the country, I'm sure. How do we go through staging, Dr. Beffa?
So I think a good way to remember staging for endometrial cancer, so first just kind of lump your numbers, stages 1 through 4, into 1 is confined to the uterus. And then if you separate that out, A and B, A is less than 50% myometrial invasion of the tumor, B is greater than 50%. Stage 2 can get a little bit tricky on nuanced test questions sometimes and the verbiage, so you have to pay particular attention. So stage 2 is cervical stromal involvement. So if you see something that says cervical glandular involvement, that does not count. So it's cervical stromal involvement that makes somebody a stage 2. And then 3 is outside the uterus, and that can either be 3A, which is involving the uterine serosa or the adnexa. 3B is involving the vagina or the parametria, and 3C is essentially positive nodes. 3C1 is pelvic nodes, 3C2 is periortic nodes. And then 4 is metastatic disease. 4A is locally metastatic, so that means bladder mucosal involvement or bowel mucosal involvement. And 4B is distant mets. And that includes, because this gets a little confusing sometimes when you confuse ovarian cancer staging and endometrial cancer staging. For endometrial cancer staging, intraperitoneal disease is a 4B.
So, it's been a while since I did gyn-onc and did my tumor boards, but I know that after you do your surgery, you'll sometimes do adjuvant treatment, so chemo or radiation. Can you also talk to us a little bit about when you would do one versus the other?
Yeah, so it's also tricky in the world of GYN oncology as well. There's lots of controversy. But in general, most patients with stage 1 don't need any additional adjuvant treatment. Obviously, that's not 100% true for every patient, but talking in majority of patients in stage 1, they need their surgery and that's it. When you're talking stage 2 and above, obviously, we would be recommending adjuvant treatment. When you're talking about whether to do chemotherapy or radiation, there are many trials that go back and forth. And depending on if you talk to somebody who favors radiation or somebody favors chemotherapy, you could probably get them to argue one or the other. But in general, if we think about somebody who has obviously distant metastatic disease or positive nodal disease, most of the time, most people would recommend chemotherapy. And like many GYN oncology regimens, you would choose carboplatin and paclitaxel. Carbotaxol, that's your go-to for endometrial cancer if you have to choose a chemotherapy regimen. And then radiation, there's brachytherapy, which again just means radiation locally, so just basically a cylinder inside the vagina after a hysterectomy, which is the whole purpose of that is decrease the risk of recurrence at the top of the vagina, which is the most likely site that it would come back. And so that is given for patients who are kind of this We call it high intermediate risk, but they have some risk factors for recurrence, but not so many. And so again, there's no cut and dry, black and white decision on how to do that. And it's always a conversation in tumor board and people go back and forth. But that's one thing to keep in mind, brachytherapy. And then there's also whole pelvic radiation, and that's another potential option.
And you mentioned earlier too that for most endometrial cancer, it seems like prognosis is fairly favorable.
Absolutely. So most patients are stage 1 if they have a type 1. And again, because that's the majority, most of what I'm talking about relates to a type 1 cancer. But so, if they have a type 1 histology and they're stage 1, incredibly favorable prognosis. When you're talking about type 2s, that's a little bit different ballgame. Their prognosis is not as favorable even when they're stage 1. They frequently need adjuvant therapy even in stage 1. So that's kind of where that separates between type 1 and type 2.
Dr. Beffa, what if you have a patient who comes to you, unfortunate, someone who's 28, 29, new diagnosis of endometrial cancer, and they've, never had children and they really want to preserve their fertility? What are their options?
Yeah, so we would talk to them, in our clinic. Obviously, kind of the standard of care would be a hysterectomy, bilateral subpingo oophorectomy. For a patient who's 28 or 29, that there are a lot of complications, not only fertility, but also really premature menopause. So it's a big conversation we have with the patients. But if we feel like they're appropriate candidate, meaning clinically they're an early stage, they have one of the type 1 histologies, we often will do some imaging to ensure that we don't see any evidence of spread outside the uterus and that they, as best we can tell, they truly are an early stage. They have early stage disease. Then we can talk to them about progestin therapy. So there are studies that look at oral progestin therapy, and then we often now are most people are using progestin IUDs as well to treat these patients. We'll follow them. We'll do frequent endometrial biopsies or DNCs. Hopefully it will regress and they can get pregnant. We often encourage them to see reproductive endocrinology, and that way things can be expedited. And that way they're not off their progestin therapy for any greater amount of time than absolutely necessary. And then most of the time we recommend surgery after they're finished completing childbearing.
And I guess another interesting question regarding this, you said that a lot of these patients they require surgery for staging and presumptively as part of their treatment. But what about the patient that, say, is not able to tolerate surgery? They've got a lot of medical comorbidities, or it's disease that is like plastering the pelvis and you're not going to be able to really debulk or operate on them. What's the treatment strategy there?
Yeah. So, depending on which of those patients it is, if you put a scope in and you see that there is widely metastatic disease and you can't debulk them, then most of the time those are the patients you're going to talk about: chemotherapy, radiation. But if you have patients who have lots of medical comorbidities or for other reasons we consider not a surgical candidate and they're inoperable, then the other way to treat this cancer without surgery essentially is radiation. And that would be whole pelvic radiation.
Well, thank you very much, Dr. Beffa, for coming onto our podcast with us and chatting with us about endometrial cancer. So, Nick, let's go ahead and summarize.
Absolutely. So we started out talking about what is endometrial cancer as a sort of subtype, but the most common subtype of the uterine cancers. Again, these are cancers of the endometrial epithelial lining that make up over 90% of uterine cancers overall. These are increasing in incidence in the United States, often owing to some of the risk factors that we'll summarize a little bit later.
We also talked about the fact that there are two types of endometrial cancers. Type 1 is our low-grade endometrioid histology, and these are usually associated with favorable prognosis. They're usually estrogen-driven, and they usually have precursor lesions like EIN. And 80% of endometrial cancers are type 1 cancers. Type 2 cancers tend to be more high grade, meaning grade 3. They can be endometrioid, but they can also have serous, clear cell, or carcinosarcoma histologies. And these types of cancers tend to be more aggressive and have poorer prognosis.
In terms of those types, again, type 1 cancers have particular risk factors, including exposure to estrogen, whether that be exogenous, such as with unopposed estrogen and HRT, or tamoxifen, and endogenous, such as obesity or states of chronic anovulation or estrogen-secreting tumors like a granulosa cell tumor. Independently from that, diabetes, nulliparity, and genetic syndromes such as the Lynch syndrome or Cowden syndrome can also be components that are risk factors for type 1 cancers. For type 2 cancers, these have some differences from the type 1 in that older patients, thinner patients may be at higher risk for them. Obesity is still a risk factor, but less so than in type 1. And again, these are not estrogen sensitive.
Clinically, most of these patients, meaning 75 to 90% of patients with endometrial cancer, will present with some kind of abnormal uterine bleeding. However, the amount of abnormal uterine bleeding does not correlate with the risk of endometrial cancer. In terms of findings, they'll normally have a normal exam and labs. However, they will likely have some abnormality on some kind of imaging, most traditionally ultrasound.
Diagnosis is always by getting tissue, whether that be an endometrial biopsy, which is probably the most common, and is reliable if at least 50% of the endometrial surface is involved. But if symptoms are persistent or you have trouble getting sufficient tissue on endometrial biopsy, a DNC is required.
Treatment of endometrial cancer includes surgery, and endometrial cancer is also surgically staged. So most patients will receive a total hysterectomy, bilateral salpingo-oophorectomy, and lymph node evaluation, whether through sentinel lymph nodes versus pelvic and periaortic lymphadenectomy. We also know that minimally invasive approaches tend to lead to lower rates of peri- and post-op complications compared to exploratory laparotomies and don't necessarily negatively impact oncologic outcomes.
And quickly, staging of endometrial cancers includes stage 1, which is confined to the uterus. Stage 1A is less than 50% of the myometrial invasion. Stage 1B is greater than 50%. Stage 2 is cervical stromal involvement. Remember that glandular involvement doesn't count here. Stage 3 and A is serosa or adnexal involvement. B is vaginal or perimetrial involvement. 3C is nodal involvement, with C1 being pelvic nodes or C2 being periaortic nodes. And finally, stage 4, bladder or bowel mucosal involvement. Stage 4B includes distant metastases, which also does include intraperitoneal disease and inguinal lymph nodes.
We did discuss adjuvant treatments, though not in detail, because this is definitely beyond the scope of this podcast, but we do talk about the fact that if patients do need adjuvant treatment, they may either have chemotherapy or radiation in the form of brachytherapy or whole pelvic radiation.
Right. Dr. Beffa, thanks again for joining us.
Thanks, guys. This was great.
Right, so once again, this is Nick.
This is Faye.
And this has been Creogs Over Coffee.
If you enjoy this podcast, go ahead and go on to iTunes, Spotify, Google Play, any of your other podcatchers, and give us a 5-star rating and review.
Find us online on Twitter at CreogsOverCoff1, on Facebook at Creogs Over Coffee, on Instagram at Creogs Over Coffee, or you can find us on our Patreon, www.patreon.com/CreogsOverCoffee, where you can give us some love and support and we'll send you some swag.
For any adjunct learning material, go ahead and go onto our website, www.creogsovercoffee.com.
Have a correction, concern, or want to send us some love in another way, email us, creogsovercoffee@gmail.com.